You saw these numbers from before, and this is kind of obviously a little bit in stark contrast to what you see in the literature, where they estimate about 50 to 80% of youth with neurodevelopmental disorders present some kind of sleep issues or insomnia or even chronic insomnia, but that it's a higher percentage than what we're seeing here. These are the usual group of medications and substances that are looked at for sleep. Again, it's not a comprehensive list, it's a select list of products. And I even went back to 16 instead of 17, and I try to stay away from more of the same, from being so categorical, to pretty much the same, right? That's instead of using all absolute terms. When we look at the work on melatonin, there's only one study by Gingras and colleagues with ASD, well, majority with ASD, that was a randomized controlled trial, which demonstrated the efficacy of it and generally how well tolerated it was. I included the Checker-Ross, but it really wasn't clear in these open label studies. And Maris is it's a continuation study of the Gingras group, right? So out of that original cohort, they were able to continue with the others up to a full year as well. Again, in support of even the other, they included in the table generally, not all the literature, but I didn't break it down into the levels of evidence, but just in general, all the other studies over the years addressing melatonin, which, as you know from what we discussed before, contains the most robust evidence in this population. There are no new additional studies on clonidine, nothing new. I couldn't even find any open labels or even any series on this. And actually, to further highlight that, Holloway and colleagues tried to start a study, but they had to close it 2 years ago because of difficulties in recruiting for that population. So, and they were just trying to get a pilot study going in order to look at funding for more in this population. There was one new study on looking at atomoxetine and sleep, but this was a group with comorbid ADHD, so diagnosed with ASD and ADHD, and found that the same group, Holloway and colleagues, that it really, the atomoxetine did not result in pretty good doses, right, up to 1.8 milligrams per kilo. Really they did not observe any significant changes in sleep during the study period. And if you remember, we've discussed there have not been any new or additional studies of diphenhydramine either. Nothing new there, right? And that if you remember from before, there was another study looking at mirtazapine by Posey and colleagues way back in 2001, and really found that not much as far as responders with mirtazapine and sleep in this group of kids with neurodevelopmental disorders. So then there really haven't been any other major studies looking at sleep in this population. So that hence the justification, the reason to keep this section brief, even though this is one of the most common, a very common presentation, as you saw, right? And if you want to look at just the basics, here's how we've presented it in the past. And I am suggesting, in contrast to what we did a little bit on the general child and adolescent guidelines, to kind of leave it the same way because of the very limited evidence that exists.